How many times you have told yourself, I'll get ECG one day, but that day never comes? If you have been trying learning ECG interpretation through traditional resources and still feel unsure, you are not alone and you are at the right place. It's not lack of efforts or intelligence, it's a hidden obstacle that I have seen over and over in my past 10 years of teaching experience. I'll break it down for you in just couple of minutes and show you what really works when it's come to mastering ECG interpretation. In this presentation, we will discuss about these untold truths about ECG in a step-by-step systematic manner. For conceptual learning, first you should have a strong foundation. This includes basics of ECG. Electrocardiography is a study of electrical activity of the heart. So we should have knowledge about conducting system of the heart. Next step is formation of various ECG waves. SA node is a pacemaker of the heart. As it fires, impulse reaches to both atria and depolarize them. This electrical activity stays on the ECG as P wave, and there is contraction of the atria. So here it is SA node, it is situated on the right atrium. As it fires, it depolarizes both atria, and this event is recorded as a P wave on ECG. And during this event, the atria contracts. So after this, impulses reach to the AV node. Here you must know that impulse cannot pass directly from the atria to ventricle because there is an insulator sheath that is known as annulus fibrosis, and this prevents the impulse to jump directly from the atria to the ventricle, and the impulse have to pass through the AV node. This AV node produces a hindrance or kind of resistance to the flow of impulse, and this is important for the ventricular filling. After this, impulse reach ventricular septum and depolarize the interventricular septum, and this is recorded on the ECG as a small Q wave. And after the Q wave, the impulse spread both over the ventricle, and most of the part of the ventricle depolarization is represented by a R wave. After this, the impulse reaches to the base of the ventricle. This is the base of the ventricle, which is represented by the or recorded as a S wave on ECG. And the last event is repolarization of ventricle, which is represented by a T wave. Now let us try to understand a life-threatening arrhythmia, but very simple arrhythmia to recognize with the help of conceptual learning. So let us take example of ventricular fibrillation. In ventricular fibrillation, as you can see, the multiple foci are firing on the ventricle due to some pathology. We start depolarizing ventricle in an asynchronous manner, and this suppresses the normal sinus rhythm. And since these impulses are asynchronous, so there will be no net depolarization. And on ECG, you will see a just fibrillatory wave, just as if some child have drawn some irregular line. So very dysarrhythmia is a very easy to recognize. Even a child can grasp it. But sometimes in clinical scenario, it can be misinterpreted. Although from after learning from the books with all those sources, although this arrhythmia is very simple, as you can see. So in clinical scenario, you can misinterpret this too. So now let us see. Sometimes you may find these kind of pattern on ECG, and you can confuse it with the ventricular fibrillation. They are untold things. These are the artifacts. Example of untold things not given in the books. Artifacts can be due to electronic interference or electromagnetic waves produced by nearby placed electrical device, or could be due to movement of the patient that we call motion artifact. So as you can see this ECG, so here you can see there is an irregular pattern. Now this can also be confused with the ventricular fibrillation, but if you see carefully, there are some places with the flat lines. This indicates that the electrodes are not properly attached. So at some places they are picking the impulse, at other places they're not picking any impulse from the body. So These kind of, this is again a technical error, you can say, or improper placement of the leads. So this can also uh, can be confused with the ventricular fibrillation. Now let us understand with one more life-threatening arrhythmia and its types. A conceptual method, ectopic foci start firing on the ventricle, and it depolarizes the ventricle directly and will produce a broad complexes like this. So although normal sinus impulse is there, but it will not get traced because it is being suppressed by this ectopic foci, and this ectopic foci, as it fire, it will depolarize the ventricle, and also there will be a contraction, but contraction will be so rapid that ventricles will not get time to fill. So you will see a broad complexes like this: tachycardia, sustained and non-sustained. The tachycardia, if you try to understand by merely theory as shown in the slide, as you can see here, it will not give you any clarity. So what picture appear inside your mind? Now let us try to understand with the visualization in a conceptual manner. You will notice in this video, initial rhythm is normal sinus rhythm. So here is normal sinus rhythm, and you can see some ventricular beats appear. So let us resume and check. Now you can see these ventricle, these beats, it will subside on their own, and you can see the rhythm is getting reverted back on its own. So this is non-sustained VT. Now this is the alarming sign whenever you see a non-sustained VT, that the same patient and after some time. So here you can see ventricular tachycardia appeared, and it is not reverting back on its own. So this is sustained VT, or normally we call it as VT in clinical scenario. So previously this was non-sustained. It was not able to sustain after 2 or 3 beats. It got reverted back. Where here, next slide, you can see the sustained VT. Now it's not reverting back. From the bookish knowledge, you will not able to make out. And this is the important role of visual memory, and you should learn the patterns with the visualization. So that is important. That's what I want to convey here. You can see here tachycardia or bradycardia. So if one have basic knowledge about ECG, then she can tell that this is the bradycardia, as QRS are separated wide apart. We are missing something here. What's that? So yes, another untold thing is calibration is not given in the book. So calibration is the machine setting of ECG machine, and you can see the normal calibration is 25 and 10. So 25 is the rotating. So this is normally 25, and this is the voltage apply in the vertical direction of complexes. Now you can see in this ECG, speed is doubled. It is 50 mm per second instead of 25. The apparent heart rate will be doubled. Although this is a normal heart rate, 75, but here it is apparently seems to be bradycardia. So this is also important thing you must consider when interpreting an ECG. And when you go to, it's okay right now we are learning, but if you misdiagnose this case in real clinical scenario or treat it as a bradycardia, then it could be fatal. Role of practice. ECG is like learning how to swim, and you cannot learn ECG by just looking other or looking at the videos and looking at the solutions. You have to jump into the water. When I say you have to jump, that means you have to practice the ECG on your own. Without this, you will not be able to learn ECG. ECG is like physical numericals. If you don't practice, you will not learn. Most of doctors think that they will learn from the books and they will go into clinical scenario and solve ECG. But this is the main problem. They don't practice. Practice play a very important role. As you can see in this video, things are entirely different. When you try to solve ECG, real clinical ECGs, we conduct such kind of real-time sessions on WhatsApp and Zoom along with the discussion, where you will get a chance to solve your each and every query arising inside your mind. These kind of discussion boost your confidence level and prepare you to interpret ECG in real clinical scenario with confident memory. One more untold thing. So as you can see, various shapes are here. So immediately, as soon as you just come across these images, immediately your mind will can recognize it like a triangle, rectangle, or square. But what about a kid who has just begun to recognize these shapes? Similarly, when you come across some new pattern in ECG, suppose RSR pattern, however, it's always require a clear descriptive picture of RSR pattern to fully understand it. Now let's create a memorable image for this as a rabbit ear pattern. You can see small r S wave and a pseudo S wave. So this is seen in the right bundle branch block. Another example is broad complexes. By definition, we know that QRS greater than 0.12 second. But do we really need to measure it every time we come across ECG? So here comes another role of visual memory. We do not need to always measure the width of the complexes, as we can see with our visual memory that there are broad complexes. So uh, we don't need to just measure every time. And some other example are, you can see here, one more example. These are the broad complexes of sine wave pattern, which is seen in the hyperkalemia. You can see here. And other example is the ventricular tachycardia, where we have already discussed about the broad complexes. There are many such patterns that require visual memory, such as biphasic T wave, Wellen syndrome, biphasic TU in hypokalemia, De Winter wave, reverse hockey sign, Salvador sign, digoxin toxicity, spike helmet, and so on. So confusing patterns are everywhere in ECG. For example, ST flattening you can see here, or ST depression or T inversion. So here you can see strain pattern which can resemble ST depression or T inversion. Sometimes you may confuse ST depression with T inversion or flattening. So these are the confusing patterns. So another example is TU pattern, and we know that in hypokalemia we see a biphasic TU pattern. But in clinical ECGs, these can appear like this, where doctor can confuse with ST elevation or tall T wave. These are not either ST elevation, not tall T wave. So here you always need a practice before going to a clinical scenario. So you may also come across the ECG like this with mixed patterns. Like you can see here, there could be a PVC or premature ventricle complexes, normal sinus beat, and also the mixed finding like right bundle branch block. It also can get confused with the PVC. And there are other findings also. ST elevation is also. And apart from that, there is a complete third degree block. Third degree block, you can see P wave are marching and hidden and RRR at equal distance. So these kind of confusing or mixed patterns are everywhere. These patterns mentioned above, it's clear that learner often get confused or struggle to recognize certain pattern, or they may confuse mix one pattern with another. So are you overwhelmed with the information but unable to apply it when interpreting an ECG? Do you often make mistake when identifying the pattern on ECG, or do you often feel certain pattern in ECG even after studying from the books? Or you may confuse one pattern with another. So these are the common problems which I have come across in my 10 year of teaching experience. Various students uh, have to face these kind of problems. So here we always use a roadmap to ECG interpretation, and I help students to develop their own unique approach in ECG according to their understanding. So now, what is the roadmap? So ECG is like a maze, or in Hindi you can say bhool bhulaiya. Approaching an ECG is like solving a maze or bhool bhulaiya with so many criteria, wavefront, confusing pattern. If you go in a random manner, then there is a high probability that you can miss some finding or can confuse one pattern with another or make incomplete or wrong diagnosis. So suppose you go for an hiking with an necessaries, all necessary stuffs for survival like tent, food, everything, but you are missing the GPS. There is no GPS. You won't be able to navigate further. This is a proper roadmap, like a GPS. You need these kind of flowcharts to interpret ECG in a systematic manner. So you can you can approach the ECG, whether the ECG is a regular or irregular, PVA is absent or present. So suppose ECG is a regular, you see regular pattern, look for the P wave. They are absent junctional rhythm, or they are seen normal sinus rhythm. Or suppose rhythm is irregular, check for P wave. Let us consider two criteria here. One is regular and irregular rhythm, and the is P wave, presence or absence. So P wave are present in irregular rhythm. So what to do next? Then you will look at the different morphology of P waves. And if you find more than three different morphology, then it will be a multifocal atrial tachycardia. And if the P waves are absent, on the other hand, you can see here P wave absent. So you can make the diagnosis as atrial fibrillation. So this is the flow chart for the bundle branch block. So are the complex are broad, as we have discussed in the previous slide. Are the overall complexes are broad. If you find broad, then go to lead V1 and check whether they are positively deflected or negatively deflected. Suppose they are positively deflected. So go further and check for the RSR pattern in lead V1. If it is present, then go to the lead 1 or lead V6 to check the deep and wide S wave. And suppose the complex are positively deflected, as you can see here, if they are positively negatively deflected, so check for the most of the part, you can see negatively deflected and also broad. Then think about left bundle branch block, and in V1 go and check the morphology, and you can also just learn this by inverted rabbit ear pattern or this by rabbit ear pattern. Right bundle branch block, this is right bundle branch block, this is left bundle branch block. So here you can see if the complexes are negatively deflected, check V1 and check for the pattern, RS pattern, small and deep S, and check for the again check for the same lead 1 and VC for the notching of the R wave. You can see here, if you see very carefully, you have to pay utter attention. And you see in the lead 1 and V6, you will see the in lead 1 and V6 both, you will see the notching of R wave. So this is how you can create the flow chart, and I provide these flowchart to my students, and it will help them but in better understanding instead of going through the all kind of theoretical stuff, and which is difficult to understand these kind of patterns. So another pattern, you know, that left anterior fascicular block, left posterior fascicular block. So these are the always remain the pattern of confusion among the doctor. So I have created the easy flow chart. So I encourage students to develop their own approach, like what they learn, they can draw and their own approach, and then later, as you can see, some of my student have created his own approach or interpretation, and then I correct their mistakes, rearrange in a systematic manner, along with the all flowchart that I have prepared. This will concise complete ECG in just 2 papers. This unique roadmap will help them to crack all kind of complex ECG appearing with a mixed pattern with 0% error. You can also develop your own personalized approach based on the heart rate, tachycardia, whether it is tachycardia, bradycardia, PV absent or normal, based on the morphology, PR interval, based on the PR interval prolonging, fixed, or there is a dissociation, as in the complete heart block, but on the basis of broad complexes, on the basis of drop beats, on the basis of STT abnormalities, and a long list is there to approach. That will assist you uh, with navigation and help you to achieve ultimate mastery over the ECG. I have created countless number of ECG champions and over hundreds of video feedbacks demonstrate the quality of teaching. And I'm on a mission to train 1 lakh doctor. Join me in a 2 interactive ECG program and upgrade your skill to an advanced level from very basics to complicated scenario. Book a call or WhatsApp me.